Welcome to the Next Gen Public Health Podcast, where public health meets leadership, workforce performance, and real-world decision-making. I am Dr. Bradley Fevrier, founder of Next Gen Public Health Consultancy. This week, we're continuing our conversation that began in the newsletter. But today, we're going further, not louder, but deeper. The hospital is no longer the center of healthcare, and the public health profession is still behaving as if it is. This is not a critique of hospitals. It is a critique of our mental model. Because when the center shifts and your strategy doesn't, misalignment becomes inevitable. Let's unpack that carefully. For more than a century, the hospital had functioned as the symbolic and operational core of health systems. Funding flowed towards it, training pipelines were built around it, prestige concentrated within it, policy concentrations centered on it. Even prevention strategies were often framed as reducing hospital burden. Think about how frequently success is defined as reducing hospital admissions, lowering ER visits, decreasing inpatient costs. Hospitals became the measuring stick of health system strain, and that made sense in a centralized model. But centralized systems and distributed systems operate differently. And whether we are ready to admit it or not, healthcare is decentralizing. Chronic disease management increasingly happens outside hospital walls. Telehealth has redefined access geography. Retail clinics and urgent care centers operate as distributed nodes. Employer-based wellness programs are absorbing preventive responsibility. Community health workers are functioning in non-clinical environments. Universities, for instance, are building well-being infrastructures that bypass traditional referral channels. Payment models are shifting towards value-based care. The hospitals remain critical, but it is no longer the gravitational center. And yet, much of public health strategy still assumes that it is. We continue designing intervention as if there is a primary institutionalized hub that coordinates care, absorbs consequences, and sets directions. But distributed systems do not behave like centralized systems. They demand coordination instead of control, and coordination is harder. Here's where the tension becomes uncomfortable. Public health prides itself on system thinking. We speak fluently about upstream determinants, structural drivers, and cross-sector collaborations. But structurally, we remain institutionally dependent. We anchor legitimacy to hospital systems. We celebrate partnerships with major medical centers. We measure impact by healthcare utilization metrics. We build academic pipelines with orbit clinical infrastructure. We talk about community empowerment, but funding structures, prestige hierarchies, and policy leverage still concentrate around hospitals. This is not moral failure, it is structural inertia. But inertia in a shifting environment becomes strategic liability. When systems decentralize, three predictable things happen. 1, authority diffuses. 2, accountability blurs. And 3, coordination becomes more complex. The hospital no longer dictates the full flow of care. Employers influence prevention strategies. Universities influence workforce formation. Telehealth platforms influence access. Public health departments influence surveillance and regulation. Community organizations influence trust and engagement. The question is no longer, how do we reduce hospital burden? The question becomes, how do we align distributed nodes? This is a fundamentally different leadership challenge, and we are not systematically training leaders for it. The public health practice gap, the one we discussed previously, persists particularly because our structural assumptions are outdated. We design evidence-based interventions under centralized assumptions. We assume linear implementation. We assume clear authority. We also assume vertical accountability. Distributed systems disrupt those assumptions. Adoptions become non-linear. authority becomes negotiated, accountability becomes shared, and shared accountability requires intentional governance design. If we continue building strategies for a centralized model, implementation friction will increase, not decrease. The science is not failing, the architecture is changing. Now let's address the profession directly. If the hospital is no longer the center, what then does that mean for public health identity? For decades, proximity to healthcare systems signaled legitimacy. Academic and public health partnerships with hospitals increased prestige. Hospital-affiliated community initiatives secured funding. But in a distributed ecosystem, legitimacy must come from coordination capacity, not proximity. Can public health departments coordinate employer systems? Can academic programs prepare students for distributed leadership? Can prevention frameworks integrate into corporate governance structures? Can implementation science operate outside clinical settings? These are not rhetorical provocations. These are operational necessities. Consider employers. In decentralized healthcare, employers function as health ecosystems. They manage benefits. They also influence health literacy. They design wellness infrastructure, and they absorb productivity costs. Yet, most corporate wellness strategies still rely on incentive structures rather than structural integration. We continue debating gym reimbursements and step challenges, but decentralization demands navigation support, chronic care alignment, behavioral health infrastructure, and cross-sector referral systems. This is a system design conversation, not a perk conversation. If public health professionals do not engage the space strategically, someone else will design it, and it will not necessarily reflect prevention science. Now consider universities. Higher education institutions are incubators for future workforce leaders. But are we preparing students to navigate distributed systems? Or are we still training them for centralized institutional roles? Are we teaching negotiations across sectors, government alignment, financial literacy in health ecosystems? Or are we reinforcing theoretical fluency without operational navigation skills? The decentralization of care exposes the gap between knowledge and application. Again, not because evidence lacks rigor, but because structural literacy lags behind structural challenge. And what about the hospitals themselves? Hospitals are not disappearing. They remain essential for acute care, specialized treatment, trauma, and complex procedures. But survival in a distributed model requires adaptation. If leadership strategies centers solely on preserving institutional gravity, it risks misalignment. If strategies shift towards ecosystem integration, prevention partnerships, and distributed coordination, hospitals remain powerful nodes within the network, rather than isolated fortresses. The distinction matters because fortresses defend, networks coordinate. Prevention becomes more complicated in distributed systems because no single entity owns it. In a centralized model, downstream hospital strain made preventions morally urgent. In distributed models, costs diffuse. Employers feel productivity loss, communities feel access gaps. Hospital feels episodic burdens. Public health departments feel funding volatility and ownership fragments. But fragmentation does not remove responsibility. It intensifies the need for alignment frameworks. Prevention in a distributed model requires shared matrices, shared incentives, and shared governance. That demands leaders comfortable operating across institutional boundaries, not just within them. Here is the professional reckoning. Does public health want to remain adjacent to structural change, analyzing it, critiquing it, documenting it? Or does it want to architect the distributed model itself? Architects must engage finance, governance, workforce economics, operational logistics, strategic negotiations. not just epidemiology, not just policy beliefs. If we resist this expansion, other sectors will design the architecture without us, and we will critique it from the sidelines. The emerging model of healthcare looks less like a fortress and more like a network. When we examine those nodes include hospitals, employers, community organizations, universities, telehealth platforms, public health leadership, public health agencies. Leadership in networks require alignment fluency, negotiation capacity, measured accountability, etc. It requires comfort with authority. It requires relinquishing the illusion of central control, and it requires acknowledging that the center has shifted. The hospital is not disappearing, as I said before, but it is no longer the sole organizing principle of healthcare. If we continue planning as if it is, we will continue solving yesterday's problems with yesterday's assumptions. The next generation of public health leadership will not be defined by its proximity to hospital systems. It will be defined by its ability to coordinate distributed ecosystems. That is the shift. And it is already underway. The only question is whether the profession is willing to adjust its structural imagination accordingly. If this episode challenged your thinking, share it with a colleague navigating healthcare transformation seriously. New episodes are released every Tuesday. And if your organization is navigating workforce health challenges, prevention redesign, or structural realignment within distributed care environments, strategic advisory sessions are available through NextGen Public Health Consultancy. Until next week, stay focused on systems, not headlines. Thank you.